Hello, Dr. David McFadden from the Dental Implant Center here in Dallas, Texas. Today's topic is full mouth implant treatment comparisons. And what we're going to look at today is the difference between 3-on-6, all-on-4, and implant bridges. Here's an example of some of those restorations. We've talked about this in other videos, but a lot of the decisions about what you're going to get actually doesn't matter how you present to the office. The doctor in most offices is going to pick what you get, and that's not what we believe in here at the Dental Implant Center. So for those of you tuning in for the first time, hopefully you'll agree with the subscribers, and that is I've always tried to present the information in a fair, educational way. So today especially I want to try to educate you rather than sell you, because the more you know about what's about to happen to you in your mouth, the better off you are. So the premise of this presentation is that every patient is not the same. Every patient deserves a unique treatment plan. Just in case you missed it the first time, every patient is not the same. Every patient deserves a unique treatment plan. So when you hear a buzzword in dentistry or anything in advertising, take a step back and consider that, if an office promotes one trademarked name, guess what you're going to get when you go to that office? You're no longer an individual. You're going to fit their protocol instead of vice versa. So because this is such a boring topic and it's going to go on for far too long, I'm going to interject some of our cases into the presentation just to give you a little bit more visual stimulation as you're trying to stay awake. So we can get through all-on-4 very quickly, and we're going to do that right now. What are the true indications for the all-on-4 protocol? One, patients have to be missing a lot of their bone already. Two, patients are unable or unwilling to go through bone grafting. Even if a patient is a candidate for the all-on-4 protocol, we believe there is still a better option. And I won't talk about that in this video, but I certainly have enough videos out there that you can find them. So just to give you an example, I've done many videos, buyer beware of all-on-4, problems with all-on-4, problems with bone removal and all-on-4. So just to give you an example, the bone reduction, there's 7 videos on my YouTube channel about the bone removal necessary for all-on-4. Angulated implants, 5 videos. Angulated correction abutments, 5 more videos. Cantilevered segments, 1 video. And the impossible restoration that results, there's 9 videos that mention that topic. So if you're interested, go to my YouTube channel and you'll find many videos about why I don't like all-on-4 and why you shouldn't either. So really, that's it for all-on-4. It's rarely ever the right treatment for any patient. Rarely ever. So we're going to really talk, the rest of the discussion is going to be based on the differences between 3-on-6 and implant bridges. Another one of our cases. So the way I want to approach this today is I want to take these 8 discussion points and go one at a time and talk through each one. So the first one I want to talk about is specialty dentistry. Prosthodontics is my specialty, and the other Drs. Tan and Dr. Lim are also prosthodontists here at the Dental Implant Center. We are the only specialty that deals with missing or deficient teeth and tissues in the oral cavity. The only one for adults. Pediatric dentistry, of course, deals with tooth problems in children, but prosthodontics is the only specialty that deals with tooth problems for adults. There are only 12 dental specialties recognized in the United States. We'll provide these links in the section below, but here are the specialties on the American Dental Association website, and I thought it was also important to show you the requirements for recognition as a specialist. Here's that link. As you'll see, even in the UK, and that's pertinent to today's conversation, because I want to address some of the things that one of the doctors from London had to say. Basically the same specialties as the United States. And what I want you to notice from these lists is that there is no such thing as a cosmetic dentist and no such thing as an implant dentist. So first I wanted to mention Dr. Semi. He's got a popular YouTube channel and handsome enough guy, and he's got the British accent that makes him sound really smart, and he probably is really smart. But anyway, even in his bio, he calls himself a cosmetic dentist. And in his YouTube videos, he calls himself an implant dentist. But neither one of those are specialties as it relates to implant dentistry, all-on-4, etc., etc. So again, I want to approach this subject as humbly and as professionally as possible. And we'll get to why I think it's important here in a minute. He talks in one of his videos about the papilla. And the only way to recreate a perfect papilla is through the materials. That this would be zirconia that brings back the pink tissues. And his argument is that the only time you're going to get a perfect papilla like this is if you do it with materials, with dental materials. Otherwise, the teeth get too square. And to a degree, I agree with him. But the big argument, my argument here is, do you want to have bone removal for making way of this entire prosthesis, which requires massive bone removal, to be able to do the pink like he shows here? He also says in that video that he's never seen a full mouth implant treatment that didn't have pink on it that looked great to him. Well, again, square teeth are pretty common, and if we have to make your teeth slightly more square to avoid bone removal, that's what every patient that's fully educated would want. And Dr. Roberts, the inventor of 3-on-6, he lists his credentials on one of his websites, where he got a master's in business at Harvard. He got his dental degree at New York University. He studied organic chemistry at Brigham Young, and he got another business degree, a bachelor's in business, from Utah Valley University. Dr. Roberts is not a specialist, and that may come as a shock to all of you. Are there talented general dentists out there in the world? Absolutely. But I've done several videos about credentialing and specialty treatment in dentistry, and it's important because I don't want the consumers to be misled. So again, I would just mention that I'm not criticizing Dr. Roberts' protocol. I will later, but right now I'm just saying that cosmetic dentistry and implant dentistry are not specialties in dentistry. So you saw that Dr. Roberts has business degrees, and I have to say he seems to be a tremendous businessman. So he started this concept of 3-on-6. There are his office and 22 franchise offices. So we did some research to try to figure out, are there specialists involved in this process? And there is one specialist in one office, and that specialist is an oral and maxillofacial surgeon, an oral surgeon. So there are no prosthodontists involved in this technique that we could find anywhere on the website. So specialty training is 3 years after dental school. So you do your undergraduate in 4 years, you do dental school in 4 years, and then your specialty degree is 3 more years to learn how to treat complex dental patients. So just think of that. 3 more years to understand the most complex treatments and to be able to render those treatments well. The other thing I'd like to point out is that we in implant dentistry, I've been in implant dentistry now for 35 years, we knew shortly after 2010 that cement retention of implant crowns and bridges was toxic to the tissues. But on the 3-on-6 website, they were doing, still to this day, January 2025, everything they show on their website still shows cement retention. And we were able to find a few videos that showed screw retention. But again, my argument back to specialty dentistry. The specialty of implant dentistry, we knew, or specialty of reconstructive dentistry, prosthodontics, we knew 15 years ago that cement was not a viable route to hold the teeth to the implants. And we stopped doing it shortly after 2010. I believe if Dr. Roberts is doing screw retention, it just started in the past couple years. And I would make an argument that probably many of the other offices are still doing cement retention. So did I cement retain? Absolutely. From 1995 until about 2010, it was the accepted method of securing the implant crown or bridge to an implant. So yes, I did it, but we learned through failures that cement was the wrong way to go. The other thing I'd like to mention about a specialty practice is that I do the surgeries, my partners make the teeth. This temporary bridge, this is the bridge given to the patient at surgery. It is handcrafted. It's individual to every patient. And all of the beautiful contours that you see here are the way we shape the tissues so beautifully. This can I would say the chances of finding a laboratory technician that can do a type of restoration like this is probably 1 in 10,000. It's very, very rare if you can find it at all. So we talk about the papilla. Dr. Semi says in his video that he's never seen an implant case without pink that had nice papilla. But this is what the protocol I've been working on for 30 years, this is what it's all about. The papilla matters, and we honor that soft tissue architecture completely from before we even touch the patient. So these types of, we call it gingival architecture, we are able to maintain and develop the papilla. Just another one of our cases. And again, yes, the teeth are a little square. I do agree with that. But this is all the patient's own tissue, the tissue they came in with. We do not take the bone away and the tissue follows only to put it back with pink zirconia. It sounds insane, but the ratio of all on 4 to implant bridges is probably at least 4,000 to 1. For every 4,000 patients who present with beautiful tissues like this, they all get all on 4 with the bone removal and the flat tissues and the prosthetic replacement of those tissues. 1 out of 4,000, of course I'm guessing, but I know in Dallas-Fort Worth, I know how many all-on-4s are being done a day, and I know how many implant bridges are being done a day. So whether I'm off by 1,000 or not doesn't matter. Saving bone and saving tissue should be everybody's first commandment. I also want to mention trademarks and buzzwords in dentistry. You know, like I said earlier, I give Dr. Roberts credit. He's a great marketer, a great businessman. And he came up with this idea of 3-on-6, and we'll talk more about the biological and mechanical implications of it. Dr. Paulo Malo in Portugal, he coined the phrase all on 4, and that term is recognized worldwide now, for better or worse, and I would say that most of the time it's for far worse. So I'll show you the homepage of my website. Many of you have already seen it. We talk about the things that we feel passionate about, but I've never named my prosthesis. I felt like it was egregious. Much like pharmaceutical companies being allowed to advertise directly to the consumer, I believe there's a ethical component to this that I've just never been comfortable crossing. Feel free to visit our website, dentalimplantcenter.com. We've got an amazing gallery of at least 100 cases. So anyway, I just show you this page because we're all committed to trying to educate our patients and give everybody that individual treatment plan. Another one of our cases, and again, I'd like to point out that we did maintain her papilla. They were small to start with from periodontal disease, but make the teeth a little squarer than they came in with. Most people don't show the gum line when they smile anyway, and even if you do, if we're saving your precious tissue, I think everybody can agree that slightly squarer teeth is okay. So the big thing that several of these are very, very technical, and I know you're going to be bored out of your mind, so I'm going to try to keep it moving along, but there's a concept called cross-arch stabilization. I want to get into that. I defined it because I couldn't find an actual definition anywhere, so implants positioned in strategic positions throughout the entire arch assist each other when met with chewing and grinding forces. So I racked my brain for months trying to figure out how I was going to describe this to the average consumer. So I thought about a number of different things, and I came back to fence posts, or fencing in general. It's not that abstract. We all know that we've seen out in the fields as we're driving through the country the single fence post, and almost always it's leaning one way or another. Either the soil failed or the wire on this side was slightly stronger than the wire holding it on this side. So that single fence post moved because it was alone in the world. So you go to the next level of fencing where you start to use the idea of bracing. These two posts are still in a linear arrangement, meaning they're in a line. So they're strong this way, but they're not strong this way. So from a fencing standpoint, we keep bolstering the fence. So now we've got a non-linear arrangement in the corner. So this fence is supported from several different directions. We can add bracing in the form of accessory posts. But the idea of cross-arch stabilization means that each implant is being reinforced by the other implants in multiple directions. Because we're turning around an arch, the implants on your left are bracing those on your right, and vice versa. And the implants in the front are bracing those in the back, and vice versa. So you have a design that is very, very stable because it's braced in so many different dimensions. Without cross-arch stabilization, and this is where it gets really technical, sorry. Without cross-arch stabilization, there's a rotational force around a horizontal axis that can cause screws to loosen or fail or break. So around a horizontal axis, as you put pressure from chewing or grinding on your teeth, I'll show you a better slide, but this is the horizontal axis and this is the rotation that I'm talking about. Using their own 3-on-6 graphic, if we connect these two implants at the base and we put these teeth on them, we're going to get rotation. As you chew and grind and you chew on the outside cusp of your upper, and that will rotate those bridges around that horizontal axis in this dimension. And the same is true in the front of your mouth. So these are the forces that are detrimental to the screws and the components of the bridge. We'll get into that a little bit more in detail here. So the clinical reality of this is that when lateral forces, and that is if you're chewing or grinding, the harder the food, the more the force, they act on the 3-on-6 restorations. The screw takes the forces as the bridge rotates around the horizontal axis, making the screw the weak link. When you connect the implants, all the screws are now protected because there's no rotational force. This is the screw we're talking about. So the implant is in the bone, and then there's what we call the occlusal screw or the restorative screw. It's very fragile. So when you get bending moments or tensile forces on the implant from the chewing and grinding, this screw is at high risk. So to sum up cross-arch stabilization and rotation around a horizontal axis, 3-on-6, each one of these bridges is just like these two fence posts connected together. Exactly the same, strong in that dimension and weak in this dimension. While the splinted bridge is like the robust fence that I showed you earlier. Connecting all the implants also gives us other advantages. We can add teeth behind the last implant. Many of you don't have bone below your sinuses. Either you go through bone grafting, or sometimes we can, many times, I'd say 50% of the time, we can cantilever the last tooth off the back of the implant. So we avoid bone grafting, and these cases are often done much more simply because we're cantilevering that unit. Here it is radiographically, where you've got basically a tooth and a half here and one tooth there. So if I only had these two implants and I tried to cantilever that, it would be a lot of force on those screws. And here's another case with an even longer cantilever. So again, trying not to remove bone, but when patients are missing bone already, we can sometimes get away with 2 whole units cantilevered off the back. But again, if I'm chewing over here, all these implants over here are reinforcing that. If I only have these 2 implants connected, then it's rotating around that horizontal axis and it's really stressing those little tiny screws. So yeah, again, I just wanted to point out, this is a patient where we were able to get an implant far enough back in the back of the mouth that we could avoid the sinus bone graft. It's another one of our cases. So the fourth discussion point is bone stimulation. Now the 3-on-6, Dr. Roberts claims that the bone is stimulated better with 3-on-6. And I'm going to call myth on this, and I'll show you why. I'm not sure he knows Wolff's Law, but Wolff's Law basically says increase in stress will strengthen bone. And this is for all parts of the body. Decrease in stress will weaken the bone. And the duration, magnitude, and the rate of force. Basically, the harder the force, the more dense the bone will become. So I said this before and I'll say it again, is that the limiting factor is the screw. It's not the bone. And it just doesn't, the statement cannot be verified. So to summarize, by connecting the implants, we're going with less mechanical failure. You can tolerate more lateral forces of chewing and grinding, thereby having more bone stimulation with a splinted one-piece bridge. I know, again, it's very technical and I apologize for that, but for those of you that give us feedback about these videos, most of you want this depth of explanation, not just the fluff. So the conclusion is, and this is after a literature search, there's been no published evidence that discusses, proves, or argues that individual bridges maintain or increase marginal bone levels better than a one-piece splinted bridge. Another one of our cases, and again I would argue about the papilla, papilla. I'll have to agree with Dr. Semi to a small degree on the papilla, is they do shrink a little bit throughout treatment. But that doesn't mean that we're going to forsake them because they shrink a little bit. So the other thing that I'm sure you've never heard before, because I think I'm the only one that's ever thought about this and discussed it. Because this was the turning point for me between individual bridges and one-piece splinted bridges. Picture's worth 1,000 words. But the basic question is, when can you connect and when can you leave the bridges individual? So in my practice now in 2025, I have a scientific way of doing that. In the past, it was just fly by the seat of my pants, but I've taken 3 million pictures of my work in the last 30 years. And when you take that many pictures and you review that many cases, you learn things. So here's what I'm trying to get at. When the length of the entire restoration is long, let's say 13 millimeters, that's a very long tooth. So long we had to use pink zirconia. And then it creates this very large, what we call contact point. That's where the two bridges come together, the contact point. When it's this large, there is no lab technician that can make it fit perfectly. So look at the length of that connection and all the different little areas where there's voids and skips and openings. So why is that a deal breaker? Well, two things. Food and food debris are easily trapped in there because there's so much room and irregularity. But worse yet, the patients can sense air passing through there when they speak. So I actually know this because I have a patient who's become a friend, and her husband took me to dinner a couple years ago, maybe more. And the whole time during dinner, she was making these sounds. And I didn't say anything in front of her, but I called her the next day and I said, "Hey, Donna, do you know you're doing that?" And she said, "What?" And I said, "You're sucking air through your teeth continuously." And so she said, "No, I never knew I did that." So a couple days later, she called me back and she said, "Now I know I'm doing it because I can hear it." And she said, "The reason I'm doing that is I always feel like there's food in there. Like even liquids feel like sometimes they get trapped in there. But mainly, I'm doing that to see if there's food stuck in there." So, not wanting to have anybody disappointed, we offered to make her a 1-unit bridge, and that fixed the problem. But that's when I learned when to connect the bridges and when not to connect the bridges. And I followed that through. I've got so many of these cases now that I'm able to follow them and make these educated decisions. So here's when you can do individual bridges. When you've got very short, or what I'd call normal to short clinical crowns. And the clinical crown is that amount of tooth structure that you see outside the gums. So basically at 6.5, maybe 7, pushing it 7 millimeters is when we can actually do individual bridges. So what it does is it creates these much smaller contact points. And the lab can make those fit very intimately so that there's not that space, or there are no voids in there. So again, scientific, not just promoting one thing over another, but every patient is not the same, right? So the problem with the 3-on-6 concept is that most of the people that come in for implant treatment have compromised tissues, and most of them have lost some bone along the way. So only 10% of our patients have what we'd call short clinical crowns. And that's just the reality, is that my patients are no different than those from Utah or South Carolina or whatever. The patient pool is the same. So therefore, only about 10% of the patients are recommended individual implant bridges like 3-on-6 for all the reasons that we just discussed. So it's a very small amount of you out there that would actually qualify for this. Another one of our cases, papilla. So number 7, are they easier to clean? Are individual bridges easier to clean than one-piece implant bridges? I did believe this, and I said it probably 1,000 times until 2021, when I realized, and it was just one of those aha moments, is that, we try to leave room for our patients to floss underneath their bridge. 70% of our full mouth reconstruction patients do not floss. 30% do. Irrelevant to the topic at hand, but the point I'm trying to make is that individual bridges are only easier to clean in 2 places if you floss. So again, the advantages of a one-piece prosthesis far outweigh the ease of cleansability, where you may not even be putting floss in there anyway. So again, I did say this many times in the past, but it wasn't true. So I will say this though, that no matter how you look at it, implant bridges, whether they're individual or connected, they're light years easier to clean than all-on-4, which is completely uncleansable. And I've got many, many videos on that also. Another one of our cases, and again, if you look at the papilla here and the papilla here, I would argue that our papilla around this tooth actually got even better. So this idea that these types of treatments are compromised from a soft tissue standpoint is just not true. Again, patient's own tissue. Why would you do anything to disturb that? And finally, you have decreased problems with separate bridges. This is another claim of 3-on-6. It's another one that I used to believe also. The reason that we did individual bridges in the past stemmed from 2 past problems. One, when we had to use a metal skeleton and put our porcelain on top of it, the porcelain chipped a lot. And there's a reason for that. Again, it's a mechanical, biomechanical reason. Dental implants fuse directly to the bone, so that they don't move like teeth. They barely move at all. So the impact moment when a tooth comes together, the teeth will give just a little bit, about 50 microns when the teeth come together. Implants only move 5 microns. So when they come together, it's literally like a solid, 2 solid pieces colliding. So we did have a lot of porcelain chipping. And secondarily, we couldn't make metal ceramic bridges that would fit around the entire arch. We could make the metal fit when it was cast, but when you put it up in the porcelain oven to apply the porcelain to it at 1800 degrees Fahrenheit, the metal warped. So we were never able to get a perfectly passive fit. These 2 problems were why I did individual bridges in the past. Zirconia has fixed that problem, those problems. It almost never chips. I can't remember one of our bridges that has actually chipped. A little piece of the porcelain came off because it's milled now. It's not cast. So zirconia has solved those 2 problems. Zirconia almost never chips. It's so hard and so dense that we virtually see no chipping of zirconia. And secondarily, it's milled. Out of a pre-made puck of zirconia, it's milled, not cast like the metal. So once it's milled, the dimensions never change. We're not applying porcelain to it. We're not interfering with the integrity or the accuracy of the milled zirconia. So really, zirconia has solved the only 2 problems that were strong arguments for making individual bridges. So let's get down to how does it manifest the differences that we're talking about today? What if an implant fails? If you have a 3-on-6 or a 4-on-8, I see that Dr. Roberts is now promoting a 4-on-8, which is much more like what we do, except his bridges are separate. So if you have 1 implant fail on a 2-implant bridge, it's catastrophic. The bridge is thrown away, the implant's taken out, and then you have to have another implant placed if you have bone. Implant bridges are just inconvenience. If you're one of the 2% that has an implant fail, it's rare, but it does happen. We put in more implants than we usually need, and if an implant fails, we simply take the bridge or the temporary off, we remove the failed implant, we modify the bridge or the temporary, and we screw it right back in. Another case. Again, taking so many pictures and reviewing my work and scrutinizing it to the nth degree. Here's a lady that didn't even have teeth, didn't even have papilla. And because we handled the temporary process right, she actually now has maybe a third of a normal papilla. But there you go, from 0 to at least something there. And again, the teeth are a little on the square side, but no comparison between this and all-on-4. Why did our protocol change? First, we place a lot of implants. That helps stability. It helps cross-arch stabilization. And if the patient has bone, we'll place 8. I've placed 10 in other cases on certain patients. The materials have improved. Zirconia has taken away the arguments for doing separate bridges. When implants fail, it's not often catastrophic. Again, I'll qualify that by saying it depends on which implant fails. But in the rare cases that we have failure, 90% of the time we recover from it without doing additional surgery. And because we put in so many implants, some of the implants are expendable. Now, don't get me wrong, we don't want failures and we don't expect them, but in the rare cases that it happens, certain implants, depending on their position, are expendable. Like I said, so with extra implants, it just gives us options for the future. And again, I've always said that when I go to if I were the dental patient, I'd want to be treated the exact same as anybody in that dentist's family, not pigeonholed into one treatment fits all. Every patient is not the same. Every patient deserves a unique treatment plan. Our final case here, and again I'll point out, very triangular teeth, some missing papilla, but this is what we were able to do for this nice gentleman. And I cannot tell you, well, you can read the reviews. Our patients are absolutely, overwhelmingly pleased with these types of restorations. So again, my final summary, my final slide, you're almost there. Keep educating yourself. Gobble up these YouTube videos as much as you can. Don't fall for trends. These words, we have patients call all the time. Do y'all do 3-on-6? I'm like, we could, but maybe we have something different for you because every patient is not the same. And finally, there is one specialty for fixing teeth for adults, and it's prosthodontics. You need to find a prosthodontist. Thank you so much. I'd invite you to leave comments below. I know this particular YouTube video is going to get a lot of comments. I hope that we've educated you more than where we started. Thank you again.